Good afternoon, everyone. We're going to go ahead and get started. It's right on top of the hour, and we're really excited to jump into today's webinar series. My name is Amora Amoige. I am the project director of the Center for Engaging Black MSM Across the Care Continuum. This is a webinar on looking at how best to leverage state policy to advocate for the health needs of Black MSM patient communities for the His Health resource. And we're really excited and really grateful today to be joined by three amazing presenters who are at the forefront of this policy work centering our state work on the needs of Black gay men. Justin Rush is a manager in health equity and prevention at NASDAQ. He currently is working on spearheading our work around technical assistance on internal health department policy, while also working to push the organization's policy positions through state agencies, legislatures, by building strategic partnerships and nurturing external partnerships, as well as supporting existing HIV and hepatitis advocacy efforts within states. We're also grateful to be joined today by Gabriel Maldonado, who is the CEO of True Evolution. True Evolution is an LGBTQ and social justice HIV/AIDS service organization serving Riverside and San Bernardino counties in California. Gabriel has done extensive work with high-risk populations through community organizing efforts, prevention services, and improving access to care and retention for persons living with or at risk for HIV. And last but not least, of course, we do have Blake Rowley, who is a manager in health equity and prevention here at NASDAQ. Blake has done extensive work as a researcher and peer health navigator on the HPTN 061 Brothers study. He has also led research underneath Dr. Matthew Miniagi, exploring substance use, potential PrEP utilization, and sex parties and pornography, and he also sits on the HPTN Black Caucus. So let's talk about our agenda for today's training. The first thing we're going to do is do a very light sort of overview about His Health, our background, our mission, and the products that we'll be developing through to our launch July 2016. Then I'm going to pass over the torch to Justin, Gabriel, and Blake, who will dive into the National HIV/AIDS strategy, our 2020 sort of outcomes and goals. We'll discuss some implications for key populations and the urgent need for state action. We'll also discuss some high-level takeaways from our His Health focus groups, where we talk with providers, Black MSM patient communities, as well as a number of med students and nurse practitioner students to really find out from them what are sort of your gaps in training, what are your gaps in terms of your needs when it comes to working with your providers to better advocate for your health. We'll also talk a little bit about the emerging His Health continuing medical education units and trainings, and finally follow up with our LEAP project, leveraging education, advocacy, and policymakers around this topic. So really sort of high-level overview about the His Health resource. We are always sort of cognizant of the fact that there are folks who have been riding with us on this webinar series from the beginning, and then we have new folks who are coming on board. As a little bit of background, in the summer of 2014, NASDAQ engaged in a cooperative agreement with the Health Resources Services Administration's HIV/AIDS Bureau, or HRSA-HAB, as we like to refer to it here in D.C., with our alphabet soup. In a nutshell, HRSA-HAB recognizes where we are in terms of the epidemic among Black gay men. Knowing that Black gay men compose about 0.2% of the U.S. population, but yet comprise 23% of new infections. There's also a need to sort of counter what we know in terms of research that is focused around disparities and any differences when it comes to progress across the HIV care continuum, and counter that with information about good solutions, great programs to show amazing promise for offering not only HIV care access services, but also preventative services. So to that extent, we work with HRSA-HAB to develop a cohort of resources and trainings to better enable providers to understand the needs of Black gay men and to accelerate both HIV prevention and care services for this particular patient community. In terms of who we are, we look at ourselves as a united community of advocates and healthcare providers who are 1,000% committed to elevating the standard of care for Black gay men. We are cognizant of the fact that Black gay men cannot address the epidemic alone and shouldn't. We certainly understand that there's patient responsibility, but to really make a shift in the epidemic, we have to move forward with an understanding that the responsibility is a shared one among patients, providers, and administrators operating at every level of our U.S. healthcare system. Next slide. And I want to talk to you a little bit about the products that we're offering on His Health. So we have identified and evaluated a cohort of promising programs that show, again, great promise around HIV care and linkage and retention, as well as sexual health service delivery that have to do with HIV, but also has to do with sort of representing the fact that Black gay men are more than just their HIV status. It is about offering services that meet their sexual health needs, and in a lot of ways thus meet their comprehensive health care needs. The second product that we're developing for His Health is a set of continuing medical education units accredited by our national partners at HIVMA, ANAC, and the American Academy of HIV Medicine that focuses on particular clinical points like PrEP access, linkage to care, whole health assessments and wellness, but conscious that within the context of what it is to offer those services in a way that is culturally respectful and culturally humble and recognizant of the needs of Black gay men as sort of whole, fully realized patients. And the third goal of His Health is to disseminate these strategies and these resources and products far and wide. His Health is in a website. HisHealth.org will go live this summer in late July, and all of these resources, trainings, and CMEs and CMEs can be found on HisHealth.org. Next slide. The last thing that I want to say is that His Health recognizes how stigma and discrimination and medical mistrust certainly are operators that sort of materializes barriers to good health of Black gay men, and that His Health is very much focused on restoring trust, breaking down silos when it comes to communication, and that is a huge pathway into sort of turning the epidemic. And we are looking to do this together with Black MSM patient communities. Just a quick check, and I want to make sure everyone can see the slides advancing. I'm going to take 1 second to make sure that they're advancing. Just give me 1 second. Thanks for your patience, folks. Just a few more moments. Through to the rest of you. I think we got it all fixed. So I sort of talked to you about how our ethos in terms of looking at those sort of social determinants of health around stigma and discrimination and medical mistrust. And lastly, I want to finish with a little bit about our vision. So our vision is looking at a world where HIV-related health disparities among Black gay men are meaningfully and vigorously addressed to no end. I want to point that out because it's a little bit different than sort of a vision to end AIDS. What we're really talking about is offering a counter-narrative to how we are reacting and responding meaningfully to the epidemic, and that is something that is at this point, I think, a little bit more in our control than what we could say about bringing infections to zero, which is absolutely a goal. But there are things that we have agency to do now as public health stakeholders, and it's important for the His Health Project to center our work around that understanding. So with that, I'm going to now pass the baton over to Justin, Blake, and Gabriel, and you can just tell us next slide.
Thank you so much. This is Justin Rush. As Amora said earlier before, I currently serve as a manager of policy and legislative affairs. Essentially what this is an opportunity for us to take the granular data that we received from the focus groups that were conducted via His Health and to be able to piecemeal together and try to put together a policy agenda for Black MSM, putting that information at the forefront within states. And what we're going to do right now is we're going to have a conversation from Gabriel Maldonado about NHAS 2.0 in regards to what the next strategies are for Black gay men and what the NHAS 2.0 means for Black gay men. So next we're going to hear from Gabriel Maldonado.
To share a little bit about the National HIV/AIDS strategy. So I don't think it was mentioned, but in addition to being an executive director of a health center out here in Southern California, I also serve on the President's Advisory Council on HIV and AIDS, and I am co-chair of the Disparities Committee. And so in my role as a member of PACHA, I've worked very closely over the last year in contributing to the updates that were made to NHAS 2.0. And for those of you who may or may not be aware, some of the key fundamentals, the goals for NHAS 2.0 have been to achieve coordinated national response to the HIV epidemic, to reduce new HIV infections, reduce HIV-related disparities and health inequities, and achieve a more coordinated response as it relates to key populations. And so the conversation we want to have is specifically looking around the disparities related to Black gay men, and particularly my passion around addressing stigma. And I believe stigma is one of the driving factors and forces around so many of the disparities that we see that disrupts the care continuum as well as prevention strategies for Black gay men. So let's dive into a little deeper. Can we go to the next slide, please? Okay, so some of the fundamental issues that are impacting Black gay men are things like family, community, spiritual support, having access to jobs, economic independence and opportunities, particularly in areas that already have high prevalence of unemployment rates, access to education. And when we say education, we're not only talking about health education and literacy, but we're just talking about quality education that creates upward mobility for young Black gay men in general. Specifically as it relates to HIV, we know that HIV criminalization laws is at the forefront when it comes to policy issues, particularly in areas of the South, of the Deep South, that are creating barriers for Black gay men to disclose, creating safe spaces for disclosure, for them to have opportunities to get tested, and for them to be able to have healthy conversations with one another about sexual health. I have found that here in our region, despite the fact that we are in California, that there is a very severe gap in MSM literacy for providers. We, many instances, have to explain to our providers that Black gay men have anal intercourse and that it's important for us to have STD and STI checks in the anal cavity. And sometimes very basic conversations like that with providers need to happen. And so we can only imagine what some of the gaps in MSM literacy can be in other areas that don't even have the level of sexual health education and cultural competency that we do here in California. Proportionate HIV funding is also a really big hot topic. I know that a lot of the call in the NHAS has been to redirect and prioritize regions that are of highest prevalence, of highest incidence, particularly in the southeastern region of the United States. And we are also looking at advancements and expansion of biomedical interventions such as PrEP access. One of the greatest cornerstones of the Obama administration has been the implementation and passing of the Affordable Care Act, enrollment, and then looking at diagnoses, retention, and viral suppression in working in conjunction with these newly expanded payer sources around the country. Next slide. Okay, so when we're looking at intensifying prevention efforts, the areas that are most highest hit in the country are areas in the Deep South. I spent a lot of time recently in Baton Rouge, Louisiana, attending the Young Black Gay Men's Leadership Initiative. And not only did we get an opportunity to talk about, the issues of Black gay men across the country, but I got to see and experience a little bit of what the surrounding city was like in Baton Rouge. But areas such as Baton Rouge and Atlanta and areas in South Florida, they also have very similar experiences with being very underserved regions, particularly because of the social and socio-political conditions in those areas. Rural communities are particularly disenfranchised and marginalized, particularly because of their lack of access to transportation. And here being in Southern California, the area that I live in is actually considered a rural territory of Southern California. We have very vast desert regions. And for us here, it can take sometimes an hour and a half to 2 hours for our patients to access infectious disease specialists in the region. And so when we look at areas of the South and how there's already disparity gaps existing there, for rural communities, it makes it that much harder to access the resources that are even available in those areas. For support and strengthen integrated HIV and related screenings, we're seeing right now around the country, I call it a revival of methamphetamine. I don't know if that's an appropriate way to frame it, but at least in the communities that I work in, we're seeing a large number of young people that are beginning to re-engage in the use of methamphetamine, cocaine, and we can have many, many inferences about why that's surfacing or what some of the reasons are, but the reality is that substance use has often been used as a coping mechanism to unresolved or unacknowledged mental health trauma or experiences. Recently, the True Colors Fund ran a campaign that highlighted LGBT homelessness as disproportionately impacting LGBT youth, particularly LGBT youth of color. And some of the largest driving factors behind that has been being kicked out by family. They ran away due to family issues. And we can infer from that that it came as a result of extensive amount of trauma, of pain, and we need to be able to address not only Black gay men from a sexual health lens, but also from a mental health and substance use lens. And that's one of the key fundamentals in the National HIV/AIDS strategy, specifically in goal numbers 2 and 3, as it looks at access to care and improving the overall health outcomes for people living with HIV. So that's addressing other issues that they may be having, such as housing, access to transportation, comorbidities, food. Like, these are all wraparound services that are really, really, really crucial to providing for Black gay men around the country. And I think as states begin to look at planning and outlining their own implementation plans and their own strategic planning, taking into consideration not only your internal public health strategies around substance use, STIs, mental health, viral hepatitis, but also how are you enabling and empowering the community-based organizations and the AIDS service organizations that you fund or coordinate with. And so I know that here in California, we work really closely, the support service agencies. The agency that I run is considered a support service agency. So we primarily do housing assistance, transportation, mental health. We work really, really closely with the local medical providers to try and get as close as we can to offering wraparound services in a very locale environment for our patients and our clients. And so I think that that is a model that really should be replicated around the country. And anything states can do to create these kind of integrated service delivery plans really, really will benefit the wholeness of the different issues that Black gay men experience. Can we go to the next slide? So taking steps to increase capacity of systems as well as diversity of available providers for people living with HIV. You know, some of the strongest and most robust providers that we have are the small community-based organizations. Those are the ones that are on the ground. Those are the ones that have their hands deep into community. Those are the ones that have their pulse on some of the high-risk transient populations, specifically the LGBT homeless youth. So working with youth that are under the age of 18 or youth that are chronically homeless that are moving from jurisdiction to jurisdiction. Many times the community-based organizations are the ones that have their hands on those key populations. And it's really, really crucial that we work on building those capacities and looking at those systems and integrating those small community-based organizations into the broader AIDS service organization model. And many times the small CBOs are left out of that kind of overall care continuum package. I know as a small CBO, I sometimes have to fight for food at the dinner table with the reigning titans of ASOs that are our primary medical providers in the region. But really, especially as we are advancing the landscape with the Affordable Care Act, we're seeing that there is a need for reprioritizing dollars, specifically around Ryan White. So one of the many hats I wear is I also serve as vice chair of my Ryan White Planning Council in our region. And we found that because of the Affordable Care Act, there was a need to redirect Ryan White funding to actually the support service categories. So food, mental health, substance use. And we found that a lot of the agencies that had been primarily focused on outpatient medical treatment didn't necessarily have the expertise to execute those other support services. It actually fell onto the hands of small community-based organizations who actually already had their hands vested in community and had the technical experience and the cultural competency and the cultural trust, right? There's also a trust factor that needs to be built when you're talking about these key populations such as Black gay men. And sometimes these community-based organizations were actually more effective than some of the larger medical providers. That doesn't mean that there isn't a role for everybody. It means that there is this call for us to looking at the capacity of our systems as a whole and to diversify the number of available providers to address people living with HIV in these very key, sometimes nuanced, circumstantial, very transient populations. And it can be very messy, it can be very confusing, and the needs of Black gay men range everywhere. They range everywhere. And it's going to be a call for us to have these strong partnerships with our Office of AIDS at the state level, working with our federal partners who provide and redirect federal dollars such as SAMHSA, such as CDC dollars, Ryan White dollars, and working with community-based organizations at the ground level to achieve this coordinated response. Can we go to the next slide? Okay. So now we're getting into my passion. This is what I am most excited about. So when I first got onto the President's Advisory Council, I was first made chair of the stigma work group, and that has now blossomed into the overall agenda of the Disparities Committee, to which I now am a co-chair. And as we know, stigma has existed since the AIDS epidemic first landed. And I think some have asked me, has stigma gotten better? I don't like to use the words better because I don't think there's anything good or bad or better or less than when it comes to stigma. I think stigma has transformed. I think it has mutated itself. I think it has become more ingrained and it becomes more subconscious into how we perceive and how we look at people living with HIV. We still have a large amount of health literacy that needs to be done on the modes of HIV transmission, on the messaging that is done at the state and the local levels, on how HIV is transmitted, on ways of it being contracted, and on the people that are affected by HIV. There is still a large number of people in the country who believe that HIV is a gay man's disease. And that perception puts a lot of other high-risk populations, such as women, at risk for this perception that is only compartmentalized to a very specific population that are engaging in a very specific behavior. And we know as a result of what's happened in Indiana around intravenous drug users that that's just not the case, that HIV is transmitted and is affecting a large number of people that range from different races, and sexualities and gender identities and socioeconomic backgrounds. As it relates to Black gay men are existing at a very unique intersection. They're existing at the intersection of homophobia, racism, and then you throw on stigma, which many times their issues involving stigma come from their own homes. There's a large number of Black gay men that I work with that have fallen out of care. Most of them are under the age of 24 years old that have fallen out of care as a result of not having family support. And the ones that did have their family were aware of their status, they actually received negative responses, that this was as a result of their gay lifestyle. And so when you look at the needs of Black gay men, they're not just addressing HIV/AIDS from a sexual health lens. They're addressing HIV/AIDS as spiritual, Black, queer, gay bodies. And that is something that they're bringing into a clinical space with them everywhere they go. They're bringing the fullness of their identity. And so when we look at how we're going to create strategies to addressing the needs of this population, we can't approach it from a single vantage point. We have to approach it from a holistic and whole perspective that these individuals are showing up into a space with multiple traumas and multiple intersectional layers of oppression that they are experiencing. And so one of the strongest things that we're seeing is violence that is experienced by Black gay men, particularly in partner disclosures. There's been some incidences recently around the internet with people disclosing someone's status, and we don't know what the violent repercussions of that public disclosure is, what that person's sexual activities or practices were in their own private lives, and who knew about their status and who didn't. But because of HIV stigma, these individuals are now confronted with a range of possible reactions or repercussions as a result of their status being outed. And that is many times fueled by misperceptions around stigma and violent perceptions about HIV. So we need to mobilize communities to reduce HIV-related stigma. And as I said before, one of the key ways that we can do that is, one, to promote more comprehensive health literacy to our communities at large. Two, address HIV/AIDS literacy from a faith-based lens, which, as we know, a large number of populations of color, namely the Black community, exist in spiritual faith-based spaces. And so it's really important that we empower our local faith-based leaders and institutes to have a working knowledge and a literacy around HIV/AIDS, and for them to be able to use the pulpit and to be able to use their ministries as a vehicle for delivering compassion and understanding for people living with HIV, as well as promoting the public leadership of people living with HIV. I think that is very, very crucial. And as a person living with HIV myself, I think it's really important that when I come into a space, I have a very specific working knowledge, not only as a professional and as a public health practitioner, but a lot of the things that I'm telling you is coming with passion, because these are things I've experienced and am experiencing every single day. And I won't get too personal so we can keep this conversation professional, but I will say that taking my hat off as a practitioner and putting my hat on as a Black gay man living with HIV, as someone who is educated, as someone who is serving on all these advisory committees and councils, and someone who gets the opportunity to speak at these high-level events, I go home and the trauma that I experience with having to disclose my status to new partners is still painful. It's still painful, even with all of the mastery that I have in this field and all of the self-efficacy and confidence that I have. It still can be traumatic. And so now if I can kind of take that understanding and I look at what some of these young, sometimes not even out of the closet, young Black gay men, particularly in the Deep South, particularly in the Deep South in rural communities, particularly in the Deep South of rural communities from religious backgrounds, what level of confidence are they coming into the space as people living with HIV, addressing stigma, addressing trauma, addressing the retaliation that they receive both verbally, physically, emotionally, and psychosocially? How are they navigating that? And how does that play a role in their continuum of care? And so I just gave you a whole lot of information and a whole lot of very complicated intersectional situations that occur around Black gay men. So if I can give you something concise and something very specific to take away, It's that we need to invest more in community-based organizations and AIDS service organizations that are reflective of the populations that you are trying to serve. 2, that you need to empower those organizations to have the systems and capacities to meet the goals of strategies such as NHAS and the individual implementation plans of the states. And 3, when you're crafting these plans, please have young Black gay men living with HIV at your table, because they're going to be able to explain to you and give you very specific examples and strategies and solutions that are going to be tailored and customized to your jurisdiction. So without them at the table, you're going to be doing a guessing game in the dark, and that is not a great place to be. And so having your strategies reflective and written by people living with HIV who are of the population that you are serving is crucial and fundamental to achieving our Getting to Zero plan around the country. Do I have another slide, Justin? Click to the next one. No, I don't. Okay, so I think that's it. So thank you, everyone. That is my little piece. And I don't know if we're going to take questions now or at the very end, but I am open for questions if anyone has any.
Awesome. Thank you so much, Gabriel. We're actually going to go all the way through and then take questions at the end. So
wonderful.
All right. So this is Justin Rush again, and thank you so much to Gabe. And he's really hit on some great points. And of note, I think that I'm going to try to tie all of that together with some specifics as to what we can do on the state level, some things that we're going to be trying to do as we continue this project forward, thinking about policy and advocacy within states. So just a little bit of information about where we're getting all of this data from. And as part of his health, we initially hosted a number of focus groups with providers and focus with Black gay men across a number of jurisdictions. And we essentially came up after we got the granular data, and after we evaluated, we know what's working. So care that's client-driven, care that is client-centered, assets-based versus deficits-based. This hits to the point of the fact that Black gay men are particularly tired of being told that they are the face of HIV, and we are more than HIV. We are the totality of everything that Gabe mentioned earlier, but we are resilient, and that's something that we found out through the focus group. Black gay men are absolutely resilient, and that is something that we want to hit home on, not just the fact that Black gay men are quote-unquote the face of HIV. Blake mentioned this, Gabe mentioned this just a second ago, but the importance of leveraging partnerships. So whether it's faith-based communities, whether it's supporting CBOs, whether it's the business community, looking towards non-traditional partnerships and establishing non-traditional partnerships and being innovative in refreshing traditional strategies, that is something that is so very important and that we're seeing that's working. Part of our debut in July is going to be rolling out some of these continuing medical education and nursing credits, and you'll see that what's really working is just getting to the bare bones of meaningful community engagement and refreshing traditional strategies that have worked in the past, and then reinvigorating those strategies. And then also the importance of promoting sexual health. So this idea that if a Black gay man comes to you and says that this is the reality of my sexual health, then that is the reality, and those are the confines that we should work within. It's not necessarily condoms, and crisis. The point is that we are supposed to tailor our care to the individual as they come in front of you, as they are in your doctor's office, as they are in your setting, and promoting sexual health and sex positivity is something that is important to Black gay men. Next slide, please. Again, some more takeaways. The patient-provider relationship is very, very important, and those communications through the focus groups we've seen are out of sync. But Black gay men definitely want to be able to have a trusting relationship with their provider. They want to be able to share information with their provider, but they're a little bit nervous. You know, I am someone who, I'm very clear about the fact that I say that I'm privileged. I've had Blue Cross Blue Shield federal insurance all of my life. Everybody does not have the tools or has not had the tools to be able to go into a doctor's office and say, these are my needs, this is what I need help with. You will help me in the way that I need it, or I may or may not just walk out. And I understand that people may feel some type of way about that, but that level of of power and sense that I feel when I go into a doctor's office. Everybody doesn't have that. And Black gay men are resilient. They want to build trusting relationships with their providers. The stigma, provider bias, language, not being able to necessarily understand the totality of circumstances or intersectionality that Black gay men are facing is something. There's a disconnect, and currently serving as a disconnect between patients and providers. So all of what we're going to discuss within the remainder of the webinar is how we can move providers and other individuals forward to unite with Black gay men, to educate Black gay men, educate community, but also advocate for and with Black gay men. Next slide, please. And so just a few recommendations based on the information that we received from the focus groups. And again, this dovetails really nicely with what Gabe has already talked about. You need to strengthen the existing networks of culturally responsive providers, those that are competent, those that are knowledgeable of other people's culture, and then use that knowledge to infuse the type of care that they're providing. Also, we need to create infrastructure for community advocacy, which ding, ding, ding is very important because that's what this is all about. How can we reimagine and reframe how we think about doing this work, and how can we support individuals or support providers in being culturally competent and being culturally responsive. It's an ongoing process. It's something that never should end, and someone should never think that they should be able to get a certificate and then they are therefore competent in someone else's care. That's not what we're advocating for. What we're advocating for is a lifelong learner model, and we should support system mechanisms that can compensate for family rejection. So whether we're educating on sexuality and relationships, stigma, providing supportive services, these are very key in the healthcare delivery system to be able to help Black gay men successfully navigate the HIV care continuum as well as the healthcare delivery system as a whole. So those are just a few recommendations. Next slide, please. And then, as we talked about before, and this will likely be talked about on many of the other webinars in more detail, part of what we're doing with His Health is coming up with some continuing medical education and nursing education credits, so where we can increase the capacity and quality and effectiveness of health care and for providers. Providers want to be able to know more information, but they have a lot of questions and they don't necessarily know who to go to. And we think that it's very important that if we're thinking about linkage retention and viral suppression, that if we work with our partners that are listed below, ANAC and HISMA, that we will be able to create something that will speak to what providers want to know and speak to what they don't know, and then help them understand more about the specifics of being LGBT, being a Black gay man, and how those experiences impact one's ability to navigate the healthcare delivery system successfully. Next slide, please. So again, all of this leads us to the work that we're going to be doing and how we're going to be moving this work forward in the future. And this comes down to a policy and advocacy strategy to move Black gay men forward, to hopefully help Black gay men successfully navigate the HIV care continuum. Next slide, please. And so this brings us to what our priorities are going to be moving forward. And this is all fueled by data. This is all fueled by our focus groups. We want to work on 3 primary issues, and these have all been touched on so far throughout the webinar. So one, we want to make sure that providers are competent. We want to make sure that they are armed with the information and tools that they need to be able to reduce stigma in provider settings. We want to make sure that they are specialized and have knowledge about LGBTQ competency, specifically on best practices as it pertains to Black MSM. So number one is that we want providers to be competent, and we can do that through concerted advocacy, which I'm going to walk through how we get to that point. But these are our priorities moving forward as a His Health. And then 2, ID access. So we just talk about all the time the bar before the bars, how stigma impacts one's ability to get tested, to get linked to care, and to ultimately achieve viral suppression. But we never really have a conversation about what about those individuals who have been kicked out of their home because of stigma, because of lack of information. But because they've been kicked out of their homes, they may very well live in a state that in order to get enrolled into care, they have to then go back to the individuals who kicked them out of their home to receive consent in order just to get an ID, in order to be able to access services. And so that's something that's often been left out of the loop. The Center for American Progress has done a lot of work around ID access, but the bar and the bar before the bars is something that NHAS has talked about at length. But A person can't gain access to services if there's stigma and all of these myriad things going on, but also if they don't have an ID, because you need a government-issued ID to access these services. So we want to be able to provide education and mobilization around the impact of state policies that create unnecessary hurdles for homeless young people or people who aren't necessarily homeless but don't have the support to be able to go back and then receive consent in order to receive an ID. And we want to be able to make that as seamless as possible. So there's legislative things that can be done in state levels. There's also things that can be done within agencies and funding that can be provided. I'm going to walk through that in just a second, but provider competency and ID access is something that is so very important for Black gay men's ability to navigate the healthcare delivery system and the HIV care continuum successfully, as well as education and mobilization around HIV criminalization. Gabe mentioned this before, but there are a lot of people. Let's just say I was born and raised in a small town in Mississippi. Of 28,000 people, I guarantee you that there are a lot of people there that still think that you can contract HIV from being spat on or from biting. So these modes of transmission that we know really have a negligible risk associated with them per the CDC, but everybody doesn't work in HIV. I can say as someone who hasn't worked in HIV for an extremely lengthy period of time, we a lot of times keep information in silos. It's very valuable information. We are very literate when it concerns HIV modes of transmission, HIV testing stigma, but is everybody else? And I think that that's a question that we have to ask ourselves. And all of that lack of information, that lack of health literacy fuels people's opinions around HIV criminalization and whose responsibility it is to ensure that disclosure has been provided. So when we're thinking about all of this, provider competency, ID access, HIV criminalization, moving forward, we're going to actively work with, as Gabe said, CBOs and community, leveraging experts to be able to provide hopefully equitable outcomes for Black gay men. Next slide, please. And so this goes into what we can be doing in regards to helping to move these policy pieces forward. And I do believe that we do have a pathway to competency. There's been a couple of pieces of legislation, one very recently in 2015, 2016, but the DC LGBTQ Cultural Competency Continuing Education Amendment. There is a requirement now moving forward within DC that medical providers receive 2 continuing medical education credits through LGBTQ competency training if they're going to renew their license. So it doesn't matter who you are, if you are considered a medical provider under the definitions of the DC regulation, that you therefore have to receive 2 continuing medical education credits for LGBTQ competency training in order to maintain your license. And in as far back as 2005 with New Jersey, we have a cultural competency legislation. This is not something that's specific to LGBTQ issues, but it's an example of how the Board of Medical Examiners and the Commissioner on Higher Education have to come together to set the standards as to what number of hours medical providers will have to receive in regards to training. Currently in New Jersey, providers are required to receive 6 hours of training in cultural competency in order to maintain their licenses. And this speaks to the fact that, you know, a couple of months ago, I had a friend of mine who is in medical school, last year of medical school, who called me and wanted to ask me questions about PrEP. And I'm like, you're supposed to be the expert on this, but they're coming to me and they're asking me about it because they don't know the specifics of the LGBTQ experience. They don't know the specifics of Black gay men being able to navigate the healthcare delivery system. And it's important that we want to make sure that they're as educated as possible and armed with cultural information that speaks to Black gay men. And the pathway to competency that we have so far with these 2 pieces of legislation is that it serves as a blueprint for us to be able to go to other jurisdictions and say, this is something that progressives are doing. This is something that they're working on. You have the tools and the ability to be able to help corral medical providers into a culturally competent space, but it cannot be done unless they are required to receive additional training. We can't expect them to have all of the tools in the toolbox if we don't give them to them. So next slide, please. Next slide. Okay. And this brings us to bear in mind, why do IDs matter? I touched on this a little bit before. There's not to be clear, a lot of data in regards to identification, but there was a 2006 survey that found that only 21% of respondents ages 18 to 24 in the U.S. they lacked a government-issued photo ID. Among African Americans, it was 25%. There are a number of different factors that contribute to this, but a lot of people are fleeing violence, abuse, or hostile environments. Others are dealing with substance abuse issues. This often leaves them on the street without identification. And again, how are they supposed to gain access to services if they are not able to simply have a government-issued ID that they're going to need in order to be enrolled into services in many cases? So the need for advocacy around ID access and provider competency, we feel like are very, very important. And moving forward, we are going to be discussing how we can provide capacity to be able to advocate for those with Black gay men and on behalf of Black gay men. Next slide, please. And again, this is just more information around ID access. Only 25% of states offer free or reduced cost ID cards to homeless youth. 50% of states require some form of parental consent to issue an ID card. Again, this goes back to hostile environment. How realistic is that for an individual who's been kicked out of their home at the age of 15 that would like to gain access to services, and then they have to go back to their mom and dad's home where they are not getting the love at all? And then 12 states have 0 protocols for assisting homeless ID card applicants. So again, I think that this is something that has gotten very little play in the realm of HIV and viral hepatitis. This is not something that I've ever heard be discussed before. And we talk about stigma, and it's very important, but there are also things that impact people's ability to be able to navigate the healthcare delivery system, and if they can't get enrolled in the healthcare delivery system, then that's a major problem. Next slide, please. And HIV criminalization. Again, this gets back to health literacy, HIV literacy. Generally, it's lacking, especially, let's just say, for instance, among people, everyday people, but legislators within state legislatures. We've had the opportunity to go to Georgia and a couple of other places, and I literally had to walk through and hold people's hands. These are people who are making very real decisions about the lives of Black gay men that had no idea about PrEP. They had no idea about that you could not contract HIV from someone spitting on you. They just were completely in the dark as it pertained to HIV, and these are people that are passing literally 300 to 350 pieces of legislation within any given legislative session. So there's, across the board, low levels of health literacy, and the legal and public perspective on HIV is based on outdated medical science. So a lot of people were around in the 80s and 90s when HIV was a very different disease, and a lot of people are not as caught up on viral suppression or antiretrovirals. They don't know anything about PrEP. So we need to be able to provide medically accurate information, and we need to provide LGBT inclusive information and engage individuals that are not literate on how to become HIV literate. Next slide, please. And this all bears into mind, how do we do that? I know I've just been rattling off a lot of things that are wrong, but I definitely want to provide a solution as to how we get there. And I say that we get there by leaping forward. And essentially what we would like to do is implement Project LEAP. This stands for leveraging experts, advocates, and policymakers. We want to bring everyone together, and this goes back to Gabe's point. You can't advocate, you can't make strategies on behalf of Black gay men unless you are informed by Black gay men. That nothing will get you in hot water like coming up with a plan or coming up with a strategy or coming up with a communications platform that is not informed by Black gay men. You will get chopped. So I think that it's very important that if we bring experts to the table, experts being providers, experts being people like individuals from NHAS who work in this field, who are very, very, very knowledgeable about the state of HIV in any given jurisdiction. We bring in advocates, those people on the community-based level, like Gabe said, that have an idea of what's going on the ground. They have the relationships. They are, in many cases, the gatekeepers to the community. And then also you need to bring community into that space. So that includes Black gay men. So Black gay men fall within the advocate space because, and this is a conversation that I had with Blake and our deputy executive director the other day, out of all of the young Black gay men that currently work in HIV, I can only think of a couple literally 2 or 3 that are currently working in a policy and advocacy or a policy and legislative affairs role, and that's including myself. I feel like a lot of us are generally kind of apathetic around going to the Hill and advocating for ourselves, going within state legislatures. There's been so many times where I've gone to a state legislator and been like, hey, this is the state of HIV as it pertains to Black gay men, and they have said to me, I want to thank you because I have never had a Black gay man in the state of Alabama, let's use as an example, come to me and say, this is what's impacting my life, this is what's impacting my community, and this is what you can do to try to make equitable outcomes. Across the board, I just feel like we are not engaging in the way that we probably need to, and that's probably because we don't know how. We may not necessarily have the tools, and we're going to get to how we're going to get the tools in just a second. But the final P in leaping to our goals of health equity for Black gay men includes advocating and educating policymakers, not lobbying. That's not something that I will ever advocate for because we're not technically supposed to lobby. But policymakers, educating policymakers, giving them pamphlets, leaflets, information, talking with them, serving in an advisory capacity as they get ready to construct their legislative agenda. Well, these are things that can all be done under the guise of education, and there's a lot of education that needs to take place within state legislatures. Next slide, please. So this is just to flesh out a little bit more around what Project LEAP is. So Project LEAP again leverages experts, advocates, and community and policymakers. Initially, what we would like to do is create state collaboratives. So there'll have to be some technical assistance and engagement around working in health departments, what the knowledge is of what's going on within the jurisdiction, and providing infrastructure, do's and don'ts of what advocacy is, what policy and legislative affairs isn't. Then once we have that piece and laid down foundation, implementing state collaboratives of LEAP CAB, so LEAP Community Advisory Boards. So this will be an opportunity to bring in advocates and bring in community, bring in providers or the experts if you'd like, and then to educate and mobilize the community around the policy issues pertinent to this project, which are ID access, provider competency, and HIV criminalization. So once we've done the initial work of seeking out individuals that are pertinent to this conversation within jurisdictions, making sure that they have the information and the education and the tools that they need to be able to advocate on behalf of themselves and with community, advocating within state legislatures in regards to ID access and provider competency and HIV criminalization is something that will be a part of the state collaborative. So again, the LEAP CABs. I love my acronyms. So that's the LEAP Community Advisory Boards. And then at the end of the year, we would like to have a LEAP Advocacy Summit. So bring all of the jurisdictions in that we would like to work with in regards to the state collaboratives of LEAP, have a conversation around successes, challenges, discuss future strategy. This is just a deeper dive in how to hone our policy and advocacy strategy, coming up with better talking points, coming up with better ways to be able to engage legislators in X states, and then be able to move that advocacy forward. And I think ultimately what it comes down to is that we as an organization want to be able to provide individuals with the tools necessary to be able to advocate for themselves. So a lot of times, this is my analogy. If we're going into another country and we're trying to equalize a country from a foreign policy perspective, what we oftentimes will do is we'll go in, we'll provide education, we'll find gatekeepers, we'll try to educate them, we'll try to give them the tools necessary to be able to build infrastructure supported by the United States. But then once they have the tools necessary, once the leadership has been developed and once the leadership is there, we want to be able to allow people to advocate on behalf of themselves. And ultimately the goal is to provide equitable outcomes for Black gay men, but also to give Black gay men and community the ability and the tools necessary to be able to advocate for themselves. Next slide, please. And again, this is just a little bit more information about what the state collaboratives will be doing. So these are the LEAP CABs. So they'll be convening the LEAP Community Advisory Boards, mobilizing community around the policy issues, developing deliverables, which NHAS will play a really big role in. So one-pagers, fact sheets all for dissemination, kind of like the leave behind that you leave when you do field visits, and providing education and recommendations for policymakers and to policymakers. We've done this before, and one really great thing that came out of educating policymakers, specifically within Georgia, is after we left, they said, we are not experts on HIV and viral hepatitis, but you are. We are getting ready to go into the 2016 legislative session. We just want to run some things by you. Is our agenda medically sound? Is it rooted in science? And that relationship that we've built across a number of different states has been key in us advocating on behalf of marginalized populations, and it will be key for advocating for Black gay men moving forward. Again, we want to build state collaboratives of leveraging experts, advocates, and policymakers, and I think that in year 3 of this project, what we're going to be doing is taking all of the information that we've learned through the focus groups and that data to be able to advocate for ID access, to be able to advocate for provider competency, and to be able to advocate against the laws that criminalize HIV. Next slide, please. All right, and so this brings us to the point of presentation where Blake Rowley, he currently serves as the Manager of Prevention and Health Equity at NHAS, but he is also the Chair Emeritus of the Young Black Gay Leadership Initiative, YBGLI for short. And he's going to do some talking about what their advocacy looks like and how that can be used as somewhat of a blueprint for moving forward, of a really great example of how you pour leadership development into Black gay men, and then you provide them with the tools necessary to be able to advocate for themselves, and then they go forth, advocate for themselves in a really robust way. So with that said, I'm going to do a slight changing of seats. And next slide, please. And the next person speaking will be Blake Rowley.
Hello, everybody. So I was asked to briefly speak to you about the Young Black Gay Men's Leadership Initiative. So to provide a little bit of historical context, this was an initiative that was started about 5 years ago as a response to some data from the CDC that sort of highlighted that young men were the ones who were becoming most disproportionately impacted by the epidemic. And so the 5 young men who started this particular initiative were sort of fed up with the fact that there was the leadership seems to be very top-heavy and sort of in the older sphere. And so we wanted to make sure that our voices were heard and that we had an impact on things that were specific to HIV at that point that were coming out of the CDC or HRSA or the White House. And so what they did was they sort of gathered a variety of other young men from across the country together to begin to have critical conversations about how they could impact this, and thus the YBGLI is born. They then had their first summit, again focused on HIV, to sort of figure out what are some of the policy things and pieces we need to be involved in, as well as figuring out how can we advocate for better health outcomes, as well as parity across governmental agencies. So how are we sort of funneling money into young people via the CDC, or what is the White House's response going to be sort of as they release new documents that are supposed to be geared for increasing health outcomes for Black men specifically. And so the summit taught us a lot of things, particularly that, and I think as other people have mentioned, that we have to become much more nimble and intersectional with our work. And so that really leads us to today. This is sort of a picture of the current executive committee that has been selected for this year. Next slide, please. And so one of the main things that YBGLI has done over the past 5 years, and we just completed our 4th YBGLI Summit, is the Policy and Advocacy Summit. And the Policy and Advocacy Summit brings together a variety of different Black men who identify as men who have sex with men from across the country to talk about issues related to, initially as it starts off, HIV, but now as we've learned, sort of their lives in general. So this could be religion, it can be mental health and substance use, it can be ball house culture. And so the summit has grown significantly over the past 4 years. It started off with about 45 individuals, and now as you can see, we're at 85 participants per year with 21 committed faculty members. And so we try to select locations where there is a sizable amount of the epidemic and also use the community to sort of help shape the summit. And the summit is designed to actually, next slide. The summit is designed to increase dialogue really among young Black men who have sex with men. And part of this is one of the main things we heard coming out of the first and second summits was that Black men, particularly young Black men who have sex with men, don't have spaces where they get together and really are able to think critically about a lot of the issues that impact their lives for a variety of reasons. That could be some of them are homeless, some of them just don't necessarily feel comfortable or safe having these conversations, and we wanted to be able to provide that space for individuals. We wanted to educate and increase awareness, particularly of health policy issues. As I've said before, these health policy issues initially start off as HIV, and now as YBGLI has changed and expanded in the past few years, has found itself having to sort of include homelessness, include education, include HIV criminalization and criminal justice, as well as with the sort of Black Lives Matter movement that happens, to think about social justice more broadly and how we include social justice sort of as the framework through which we decrease HIV incidence in our particular community. Additionally, we wanted to facilitate the expansion of mobilization and advocacy efforts. And this is to piggyback on what Justin was talking about. YBGLI starts off as a national collaborative, really to focus on some of the issues happening nationally as is related to HIV. But one of the things that our summit participants have taught us is that there's an intense need for young people to get together in their regions to be able to think about things that are regional specific as well as state and local specific, and how can they mobilize in their own regions to tackle some of the issues they're experiencing. And so what YBGLI does is it helps put people into I don't want to say buckets, but we sort of categorize people regionally and provide them support to carry out initiatives in their region that they feel are pertinent to them. We wanted to develop best practices. So there are a lot of things that are happening across the country that we don't necessarily talk about because they aren't funded by the CDC, or they're not funded by HRSA, or they're not funded by some entity that we have found is sort of the head honcho. But there are a lot of really great things happening. So we wanted people to not only talk to themselves about these great things, but also talk to people who sit at a national level about some of the great intervention work that's happening, some of the great DIS work that young people are leading, some of the really great social justice things that are happening that really are started by young queer individuals, and highlight a lot of that work. And then prioritize the initiatives that will effectively impact their lives. So thinking about, we now know that HIV is not the totality of a young person's life or a Black person's life, but there are other significant issues that are occurring within this person's life. And so figuring out per region or sort of per individual, what's going to be the thing that you actually want to focus on that at the end of the day still helps to drive down HIV incidence and prevalence in a jurisdiction, but may not necessarily be the most important thing that you're thinking about right now. It can be access to food, it could be increasing health literacy for patients and providers, it can be access to PrEP or whatever it is, but we really wanted to be intentional about the type of support that we were providing people in a regional capacity. So that's sort of a little bit about what YBGLI is doing. In terms of the future, as I've mentioned, there are particular regional officers who sort of help to shape and coalesce individuals in a region to identify priorities and sort of identify scopes of work. And so in the South, a lot of that looks like provider education and cultural competency. So there are individuals who are in the South who are working intently with health departments, who are working with CBOs, and who are also working with entities that sort of just exist in the ethos in the South, really to increase literacy and cultural competency for agencies in the South. And as I said before, a lot of this work is driven by young people. And so I think that I will actually stop there because I know we're short on time, and I'm sure there are questions. So I will move to the last slide.
Hey, everyone. Thank you so much to Blake and Justin, who is here with me now, join so that Blake can have the screen, as well as Gabe for a really robust, rich conversation about sort of the many levers that we can grab onto, looking at provider engagement, looking at what we can do in terms of state legislatures, Ryan White stakeholders as well. So right now we're going to take some questions, and I don't know, Drew, if you have some queued up. Justin, I do have a few here. The first question I have from one of the attendees is, what are some of the states that you were interested in engaging in for the LEAP project?
So I think that definitely when we're thinking about LEAP moving forward, we want to focus on states where there's the burden of HIV is, and also where there's not a lot of activity or capacity currently when it concerns advocates. So thinking about within southern regions, we also have some really great rock stars within places like Virginia. We've done work in Georgia. Tennessee is getting ready to gear up to do some work around their HIV criminalization. Georgia is getting ready to consider putting forth legislation to modernize their HIV criminalization laws that criminalize HIV within Georgia for the 2017 legislative session. So it's all about figuring out what is existing within current states, within southern states, doing some work in I'm from Mississippi and I have contacts and connections within the state legislature within Mississippi and Alabama. I know that may seem like a big reach, but we need to be in places where HIV is, where there's rural communities, where there's not a lot of capacity as it pertains to advocacy, and to be able to try to piecemeal people together, leveraging experts, advocates, policymakers, and policymakers to be able to create those, say, collaboratives, primarily within southern states where the burden of HIV really is.
Awesome. Thanks, Justin. Gabe, this question is for you. Particularly this attendee was discussing what you had brought up in terms of this unique point in time that we're in. And you said something to the effect of that we're at the intersection of homophobia, racism, and stigma. And they brought up that also there's the factor around folks being fearful of Black masculinity as is evidence of the Black Lives Matter response to police brutality against not just Black men, but also Black women and children. They wanted to know if you feel that there are any lessons learned from the Black Lives Matter movement, particularly around community mobilization in cities and states.
Thank you. That's a good question. And I actually think Justin sort of alluded to it already. He stated it in his opening statements around resiliency of community. Some of the work that I've been doing on PACHA around stigma has been looking at all of the different disparities that are created as a result of stigma. And PACHA did a one-year sort of expert listening tour with experts all around the country. And there was one expert in particular who brought a notion to us that kind of caught us off guard, and we were all dead silent. And it's Anne Stengel from the International Center for Research on Women in Washington, D.C. And she said that in her research she found that stigma in some communities created resiliency, and that there was an enormous amount of power and strength and independence and activism and self-advocacy that came as a result of stigma. I guess one of the positive outcomes, right, if we want to call it that, of stigmatization for people living with HIV. And I think that, as it relates to HIV-related stigma, is just an example. It's one example of the resiliency that Black people have always had and that Black gay men have had to bring forth within themselves. Now, that's a very, lofty concept. How does that apply to public health? It applies to public health because many times we look at and approach Black gay men from this poor me victim identity. And if we approach each other with that lens, then that is going to definitely change how we inform our care and how we approach addressing the needs for Black gay men. We have to see Black gay men as resilient bodies, as people who have the ability to change behaviors, but those behaviors need to change as they change their own senses of identity and their own sense of self-efficacy. And so we have to begin there as a starting point. You have to begin with how they see themselves, how they perceive themselves, how they see their communities, how they see one another. And I think one of the quiet, best-kept secrets within Black gay men, so I hope the Black gay men on this call don't beat me up for it, but we secretly distrust one another. And that distrust creates barriers from us having conversations with each other around sexuality. It creates barriers from us being able to have conversations of disclosure. It creates barriers for us to have safe-sex negotiation. It creates barriers for able to create support systems for each other. There's this distrust that exists between us. But there is an opportunity. Go ahead.
I was just going to say, too, I don't want to be cognizant of time, but I think you're hitting on something that's really powerful, and it dovetails into another question that an attendee had, and I want to know your thoughts here. One of the attendees asked, how will some of your proposed state policies protect the interests of Black men who may identify as hetero, but in terms of behavior would be categorized as MSM? And I was sort of talking to Justin about this a little bit earlier. It could be that some of your policies would do that sort of by default. It could be that there's no way to do that. And I think it dovetails with what you were talking about in terms of trust and how that impacts disclosure. So I'm wondering what your thoughts are around that.
So I want to be intentional in answering your question correctly. If you can ask it one more time so I can know exactly what you're asking.
Absolutely. So an attendee wants to know how will some of your proposed sort of state policy initiatives protect the health interests of Black men who may not identify personally as gay or same-gender loving, but behavior-wise would be categorized as MSM. So there's a disclosure piece.
Do you mind if I try to take a stab at this initially?
Yeah, Justin, I think you should, see if you can take a stab at that, Justin.
It's a tough one.
Okay, so I think that regardless of an individual identifies as a Black gay man, them being able to have the ability to have access to an ID, even if they just one day want to go get tested for HIV, you never know, or general literacy around HIV would be helpful to reduce stigma that could ultimately help to lead for them to be able to be comfortable to be able to disclose the fact that they are a man that sex with men or they consider themselves gay. And provider competency, a provider having knowledge of the fact that there are situations where Black gay men may not necessarily disclose the fact that they're a Black MSM. A provider having knowledge of that may be able to massage their sexual history taking in a way that is inclusive or is more apt to allow for them to be trusting in that situation. So I think that regardless of if they are necessarily an out Black gay man, that these policy implications, these policies will have implications for everybody across the board, but it's specifically designed for individuals who are most marginalized, which are Black gay men.
And I think it's so powerful that you sort of state that in this forum, because to some extent there is a bit of a chance that there's a bit of an underestimation in terms of who is at risk, right?
Yeah.
Because of reporting, because of how folks identify or choose to not identify around behavior. So it just sort of bears the point even more that these sort of ameliorative steps that we're taking have tremendous impact for those who we may not even think they would.
Yeah, definitely. And I think what we're saying with this is we want to try to make advocating for yourself sexy. And I think to answer your question earlier, what we learned from the Black Lives Matter movement is that if you coalesce and if you come together and you come up with an agenda, if you're not just yelling, you're not just screaming, but you have an actual policy agenda and you are making concerted and strategic steps to try to move that policy agenda forward, we're only advocating for three things here. We're not trying to reinvent the wheel, but I think that the ability to be knowledgeable and to be able to go onto a state capitol and say, this is who I am, this is what's impacting me in my community, this is what you need to know, and this is what we need from you to be able to create equitable policies, that is very powerful, and that power is very sexy. And this is all about trying to give people the tools to be able to advocate for themselves.
Last question, and I'll sort of pose this to the group. Everyone can sort of just take a round here. Again, we sort of talked about the many levers or systems or layers in which a number of different stakeholders can engage to move forward a meaningful state-based policy agenda that protects the needs of Black gay men. In your opinion, who are the best operators of change? So who has sort of the best power for sort of the avenue that you're thinking is sort of the most important to take? And who's the best messenger? And that can be the same person, or maybe they're two different people. And maybe we'll start with you, Justin.
I think that providers have a power in a way that they don't even recognize. So this idea that when a person comes into a doctor's office, the power dynamics that play are the provider is here because you're educated, you've got MDs, you've got all of these different things. I think that if providers or health departments or CBOs were to rethink of how they advocate for individuals that they serve, that would be very, very powerful. I also think that it's very important that Black gay men are the messengers in a lot of ways. There would be nothing more powerful than having 50 to 100 to 150 Black gay men on the Capitol talking about these things, or within state legislatures talking about these issues. Nothing would be more powerful than us representing our own interests. So I think that's where I fall on it.
Awesome. Blake? Blake, I think you muted yourself.
You're absolutely right.
Back on.
I would echo this in terms of providers. I also think that a lot of the people who have been in power for a very long time still have a lot of power, and I think it's incumbent upon them to bestow that power to individuals who are a little bit younger. In terms of messengers, I do think that Black gay men are the messenger, but I think as our work becomes more intersectional, it's important and actually imperative that we include Black women and specifically Black queer women in our messaging. And I think part of that is because we know that in many ways, Black queer women are people that, or Black women are people that Black gay men trust in a variety of different settings. And so it's going to be crucial to leverage their struggle and our own struggle for our liberation.
Really good point. And last but of course not least, Gabe, your thoughts?
Mothers and fathers.
Mothers and fathers, why?
Mothers and fathers. I think that most of the stories that I hear from young Black gay men that are marginalized or displaced, many of them are just looking for a home and they're looking for a family. And you can see within Black gay culture across the country, namely the house and ball community, that there is this call for a recreation of family structures. That's how desperate and that's how yearning young Black gay men are for family, is that they went about creating an entire cultural structure to create family. And so I think that if we can empower mothers and fathers to be more health literate and equip them with the tools to be able to have conversations with their children at prepubescent and early adolescent ages, that we can go a long way with prevention before they even reach puberty. And if when they do reach puberty, maximizing their retention into care and their retention into prevention as well. So mothers and fathers for me.
That's awesome, and a great note to end on in terms of familial ties and just how we cannot grow stronger unless we look to do this together. Justin, Blake, Gabe, I want to thank you so much for your time and for joining us on the His Health webinar series. Just a little bit of promo. Next week we have a deep dive into our first set of focus group preliminary report out data. I believe that will be next Thursday at 2 o'clock. We do send out webinar announcements to our listservs. We'll follow up this particular webinar with a PDF of the PowerPoint as well as how to reach us on all of our social media. We are on Instagram, Facebook, as well as Twitter under His Health. So thank you all again so much for joining us, and we will see you next time.